Dr. Ramamurthy is going to be talking on bioptics, when and how. And I'm sure he would be telling us, I have told you how to address target emmetropia. And he is going to tell us, okay, you are stuck with a residual refractive error after cataract surgery. How best are you going to deal with this?
You can see my slides?
Yes.
Okay, thank you. I think that was a fairly extensive talk on how to arrive at target emmetropia. And as Chitra mentioned, if in case you are left with a residual refractive error, how exactly can you deal with it? I think whenever you are prescribing spectacles subsequent to cataract surgery, there is a certain amount of unhappiness that's associated with it. Not only that, whenever there is significant refractive error that's left over, it can also translate into malpractice risk for the practicing ophthalmologist. And this is something well established with several studies. So exactly, it is not only important to have access to all the formulae, the technology that Chitra talked about, but also have the ability to deal with them in case you are faced with a unequivocal situation. So obviously, when you have a residual refractive error, the best way is to prevent it. And sometimes the patients are also willing to go ahead with purchase a pair of glasses for specific purposes, just because you have never offered them or promised them absolute freedom from glasses. Laser vision correction, piggyback intraocular lenses, IOL exchange, IOL repositioning are factors that I will be covering. And interestingly for me, the fellow eye surgery is also a very important method of dealing with patients who have had some residual error in the first time. Transepithelial PRK is what we favor most often when there is a residual error. And often these patients are promised even before the primary surgery, when they're going for a toric or a multifocal intraocular lens, that there might be a need for a touch-up procedure, which will be offered free of cost at around 3 months. And often it's not just the need for glasses that goes away, but even if they have some problems with dysphotopsia, it significantly comes down. Invariably, it's small errors of refractive error that needs to be dealt with. And that's a mitomycin C, which is placed upon the corneal surface for a period of 30 seconds, irrespective of the amount of refractive error that we deal with. Some of these patients who have epithelial issues because of their age, as well as those who are averse to the irritation that it causes, because we are doing it free of cost, we most often end up using a microkeratome till I believe 25 years from the time I started refractive surgery. That's a very useful tool. And you can see the intraocular lens shining through. And very often when you address the small amounts of refractive error that these patients have, the ability to deal with it often translates to a very successful outcome in these patients. When there is a significant amount of refractive error that's left over, especially in the hyperopic error, for example, this patient was post-refractive surgery, surgery done quite some time back, had an error of +4 diopters, and it's a week later that we are actually explanting this intraocular lens. In case you can bring out the haptic like this, then you can create a small cut of the optic to a quarter of the length of the, half the length of the optics. Otherwise, you can go through the side port incision using specific lens holding forceps. And then once you have got hold on this, and you can rotate the lens out of the bag and then implant the intraocular lens of the right power inside the eye. And ideally, it should be done, especially when you're implanting a hydrophobic acrylic lens, within a period of a couple of weeks. And in case you are faced with a significant refractive error, this is one of the best ways of dealing with that, especially in the early periods. The other lens that I often resort to is a sulcus implantation of the intraocular lens, where you can see there is an anterior convexity and a posterior concavity. Because of the posterior concavity, there is a significant length distance between the primary lens and the secondary lens. And I use this whenever I'm faced with a situation where there's a significant residual error. And as you can see, this lens is about 14 millimeters in overall diameter, having a 6.5 millimeter optic diameter. And you can see this capsule is open. Here again, the simple formula is that for every diopter of hyperopia, you have a 1.5 diopters in the sulcoflex lens. And for every diopter of myopia is 1 diopter of myopic error that you correct. Here there was a 6 diopters of refractive error that was left over. And this is a +9 diopter intraocular lens, a Sulcoflex lens that's being implanted. And as you can see, the primary lens is in the bag, while this lens goes into the sulcus. Often they are of different material. And you also ensure that the haptics of the two lenses are not exactly in line with each other, but at 90 degrees to each other. This lens, again, this was actually a planned Sulcoflex lens. Actually, several formulae were showing extremely different IOL power calculation in this hyperopic eye, non-ophthalmic eye. And essentially what we thought that the patient was needing a +56 diopter intraocular lens. In these patients, you can see a +40 diopter single piece intraocular lens has already been placed in the eye. And subsequently, what we found was that the patient had a +6 diopter residual error. And again, you can see a +9 diopter intraocular lens being implanted in the sulcus. So in this case, actually, the patient was told that it would be a 2-stage surgery. Of course, you can get intraocular lenses of high power being manufactured and given to you. And these lenses come with a considerable amount of spherical aberration. And I often find that the intraocular lens power calculation itself is a challenge in these situations. So a 2-stage surgery like this is often helpful in dealing with the situation. This is just to show you the OCT picture of the previous surgery that I showed. And you can see the distance of about 510 microns between the primary and the secondary lens. And this is a slit lamp photograph of the patient who has been dealt with. Today, you also have a situation where the patients were coming in for a multifocal intraocular lens in the second eye. And often I dissuade them from that, but then in case they're insistent, we go ahead and implant the lens. That serves the patients quite well. But sometimes they want something for the initial eye where they had a monofocal lens. And you have the trifocal piggyback intraocular lenses available to you today. And this is what I'm implanting in 2 of my patients. It's not that we actively encourage this, but in case the patients having seen their relative or a friend enjoying the benefits of multifocality wants this, then this I find is a fairly true and tested technology. And I have implanted about 12 of these eyes so far. And I find that the trifocal optics of these lenses, where you can even get a power incorporated or even astigmatism corrected, does act quite well and ends up in satisfied patients. Here is a situation where you find that there's a toric intraocular lens that has been implanted. The patient has an excellent refractive outcome. It was done in a nearby town by a very good friend of mine and an excellent surgeon. The patient was a lawyer, had an optimal refractive outcome, but was extremely disturbed as far as the dysphotopsia was concerned. Was followed up almost for a period of 6 months, but then because he kept complaining, he was subsequently referred to me. I did not want to disturb the capsule because the toric lens was very well placed and the patient was enjoying a very good refractive outcome. But I went ahead and placed a Sulcoflex lens of just 0.5 diopters. I would have preferred a 0 diopter, but that was not available. And the moment I did this, the first post-operative day, because the rounded optics of the Sulcoflex lens was overhanging the square edge optics of the primary lens, the dysphotopsia that the patient had to live with and was getting disturbed with for almost a period of 6 months almost vanished. There's just one way of dealing with severe negative dysphotopsia. Of course, doing a YAG laser to the capsule which is overlapping is also a good way. Then, of course, the toric intraocular lens rotation. I have a Varion overlay in this situation, but that's not being seen in the videograph. So you can see there's a significant rotation that has occurred in this. And even for much lesser rotation, I use a Barrett RX formula, which gives you an idea about what exactly is the extent of rotation that this lens has to undergo. And it's just an irrigation cannula that goes in through one side port and using a Sinskey hook. Usually it's at 1 to 2 weeks period. If the patient needs rotation, that I go ahead and do this, and you can see that it does well. It has also been suggested in these situations, you can combine it with the implantation of an endocapsular ring, which might avoid the further rotation of the intraocular lenses. But I personally do not subscribe to my view. And I find that just rotating the lens and evacuating viscoelastic completely, that's the reason I don't use any viscoelastic in this situation, does help in stabilizing the lens, leading on to optimal outcomes. It's also important that you decide what patients actually need treatment. You can see a patient like this, a 6'9" in 6 vision in one eye, 6'6" and 6 in the other eye. Patient came in feeling extremely happy with his condition, but often your optometrist finds out that there's a 0.75 diopter of astigmatism left over. If they go ahead and make the patient realize that the last line is not so clear to them, a happy patient who walked into your clinic turns into an unhappy patient. So I often emphasize to my patients what we are looking, my optometrists, my other doctors, what we are looking at is 6 by happy rather than 6 by 6. So do not create a problem when there is none. If a patient is quite happy with the outcome that you have achieved, don't go looking around for that small 0.5 diopters of astigmatism or cylinder. On the other hand, you faced with a situation like this, where the patient has 6 by 7.5 vision recorded by one of my junior optometrists, but the patient came in with a complaint of blurred vision in the right eye, having got a toric multifocal intraocular lens implanted. So I asked one of my senior optometrists to repeat the refraction, and this is what he ended up with. A 612 uncorrected visual acuity and just a 0.5 minus 0.25 with a minus 0.5 diopter of cylinder. But since the patient was not happy with the visual outcome, we went ahead and performed a laser vision correction. This was a toric multifocal that was implanted. But when it's a myopic astigmatism and both the myopia and the cylinder are minus, rotating this lens is not going to help. So essentially, what we did was to go ahead and do a laser vision correction. And another important factor that I find is that fellow eye surgery often takes care of the problems that you created with the first eye surgery. You can see fairly straightforward intraocular lens power calculation. Patient received a Symphony intraocular lens. That was, I think, sometime in 2019. As we all know, the patient had a significant presbyopic correction, had an excellent visual outcome as far as distant vision is concerned. So what I did was to do a bit of a micro monovision in the second eye, where instead of 22.5, I went ahead and implanted a 23 diopter lens. So bilaterally implanted, what we found was that the patient achieved an excellent near vision. He was aware of the fact that there was his near vision was not so great in the other eye, but bilaterally implanted, the patient was quite happy. So essentially, I find that fixing refractive surprises in cataract surgery is essential, and it's possible, and it's an integral part of refractive cataract surgery. And that's something that we need to do in our day-to-day practice today. Thank you so much for your kind attention.
That was a wonderful talk. And I think it practically answers most of the questions which all of us have. But again, for the questions for the experts on the panel, how long do you think we would wait before we go ahead and do a bioptics or a touch-up procedure? Dr. Sandeep?
Well, Chitra, it depends on the magnitude of the refractive error. It's like if the refractive error is small and if the patient has got the other eye to be performed as well, I would first go ahead and, as Ram said, get the cataract surgery done for the other eye. And if the patient is okay with that, maybe I would tie it on for some time. But if it comes to a refractive error correction at the end, and if I have to do a laser vision correction, I would do for these small cases, I would wait for up to 3 months and then do it. However, if there is a large refractive error that has come in, then maybe we need to go in a little more urgently. It might even involve exchange of the IOL, or I could do a laser vision correction, but I would do it sooner than 3 months.
Dr. Rajiv, you had a question?
Yes, I just wanted to ask you, you are mentioning about the effective lens position.
Yeah.
Especially in the myopic eyes, when there is the lens power is minimum, so there is a change in effective lens power. It doesn't alter much the intraocular lens power calculation. Yes. But when the LASIK operated, so that your lens power is higher, and many times we feel that myopic eyes, that once to your irrigation aspiration, that effective lens position is ALP is not exactly where we think. So does it make a difference? And can we assess it prior to in a LASIK operated myopic patient? Because
in a LASIK operated myopic patient, the regular formula is not going to be there. We are going to use a Barrett Barrett RX
2K.
formula.
Yeah.
2K formula. So when you're using that, it factors in all those aspects which are there. It is not just the
But
it is also the alteration
that
on the cornea. The relationship of the anterior and the posterior cornea is altered. That is factored in, and the axial length and the depth of the anterior chamber depth, everything gets factored in. So it uses a double K solution. So it is different for the regular universal formula and becomes different for
that's okay. But then it is very case to case. Many times we feel that chamber is so deep, and many times that chamber is not so deep. So it might be going to affect the effective lens position, because sometimes the journals are weak. That might be creating that position slightly backward. And if journals are not weak, it will be slightly forward.
Yes, true. Yes, true. If zonular weakness is an entirely different ballgame. That is going to bring in a lot of its refractive surprises. So then we are looking at the stability of the capsular bag. And when there is a doubt on that, then you would have to put a CTR. But the fluctuation of anterior chamber depth during the surgery is not going to affect the post-op outcome, because once the eye becomes stable and it's in the IOL is seated well in the capsular bag with the nice overlap, I think that would be the post-op situation which is factored in these formulas. I'm sure I want the other expert panels to give their thoughts to what he's trying to ask. Dr. RAMAMURTHY?
No, I think what Dr. Rajiv is trying to ask is that, in a highly myopic patient, you have a large eye, you have a large capsular bag. But because the patient has undergone a prior refractive surgery, the IOL power that you might implanting might be a little different. And what exactly would be the impact of the position of the lens in that large capsular bag? Am I right, Rajiv?
Yes.
That fluctuation, because effective lens position in the larger power, it will be affect much the postoperative refractive outcome. Instead of
if I might, even Satyajit had asked this question, I think one of the advantages of, for example, when you are mathematically assuming the posterior corneal curvature and actually measuring, as in the TK formula, when in the universal 2 formula, etc., it doesn't really make too much of a difference. But when it comes to a post-classic eye, in which case there's the relationship between the anterior corneal surface and the posterior corneal surface is altered, actual measurement of the posterior cornea does help more significantly than the mathematical assumption in the original Barrett formula. And as far as the profile of the lens itself is concerned, Chitra also mentioned during her talk that these lenses are taking into consideration the shape of the lens, the shape factor, the principle. When you talk about the lens thickness in other formula, it essentially refers to the thickness of the lens that we are taking out. The Barrett formula is one which takes into consideration the lens and the profile of the lens which is being implanted. So whether it's a meniscus lens or a biconvex lens or a plano-concave lens, the principal meridian is going to vary, and that's being factored in. And that's the reason that you do not really have to compensate for the intraocular lens power that you are implanting. Whether it's a +30 lens or whether it's a -4 lens, quite often I find that it's the Barrett works well.
Okay. In a post-LASIK eye, if the patient has a smaller residual error, would you still like to go and treat on the post-LASIK cornea, or would you rather place it in the sulcus? Dr. Kamal Kapoor wants to answer that.
Yeah. See, Dr. Chitra, I think, first of all, I'm really sorry for joining late. There was some emergency I got caught in, but I think better late than never. It depends. What is the post-operative time period? Let's say this patient has got a minor error, which is just maybe immediately post-op. So then you know that there's some issue with your machine, the settings or the OT or whatever. Then probably I would not hesitate to lift the flap and probably ablate the cornea rather than open the eye and put in an IOL. But let us say I see this patient after a period of time, let's say 2 years, 3 years. That is the time I would like to watch out before I touch the cornea, because, sometimes these corneas have some creeping issues, hidden issues, which they are probably, manifesting 3, 4, 5 years post down the line. So just probably do their posterior corneal curvatures, do their pentacams, and observe, is there something happening there or not? And if I'm not sure, either I would refrain, tell the patient to wear some glass, maybe if it's a small little power, or if I need to decide for surgery, and if I'm slight doubt, I would go in for a piggyback lens. That's for my personal opinion.
See, I don't think in an older age group, ectasia is going to be a problem. You should have looked into the ectasia before you go in for a premium IOL implantation anyway. So probably I was just wondering that you would not touch the cornea if the abrasions are more.
Absolutely.
Do you want to add anything to it? You are muted, Dr. Naren.
Thank you, ma'am. So in terms of abrasions, definitely, let's say preoperatively itself, if I'm seeing a lot of abrasions, I would treat that first as primarily, provided it is safe to do that kind of a treatment in that particular eye. And so that my predictions, once the cornea is much more regular, my K readings are much more reliable. And, and the position, the post-surgery also, patient will be seeing fantastic, even without treating it. If you put a monofocal lens, patients still have a little bit of glare and, some amount of disturbance because of the lot of abrasions in the eye. I would prefer to regularize it first and then plan for the cataract surgery.